Good afternoon, everyone. Thank you so much for joining today's webinar. My name is Julia Resnick. I'm Director of Strategic Initiatives here at the American Hospital Association, and I will be your moderator for today's event. So in the past month, we've seen two major natural disasters hit the U.S., devastating communities and leaving residents struggling with scarce resources. And our hospitals in those communities had to be prepared for whatever challenging situations came their way. We know that these disasters, both natural and human-made, will continue, and we have to be prepared for the unexpected. Yet, while 30 million children seek emergency care across the country, more than 50% of hospitals' disaster preparedness plans do not adequately address the health needs of children. And that's why we're here today. We're very fortunate to be joined by healthcare leaders in the pediatric disaster preparedness space who are dedicated to creating and implementing evidence-based practices and protocols for emergency departments to address the needs of children experiencing the impact of disasters. So a little bit of background on why we're here. In 2019, the U.S. Department of Health and Human Services Assistant Secretary for Preparedness and Response funded the development of Pediatric Centers of Disaster Excellence. The hospitals with us today, Corewell Health Children's and University Hospitals Rainbow Babies and Children's Hospital, were selected along with 4 other hospitals to develop best practices on disaster preparedness and response. So joining us today, and they'll give you more thorough introductions to themselves when they start their slides, are Dr. Matthew Denenberg from Corewell Health Children's, Dr. Deanna Dahl-Grove from University Hospitals Rainbow Babies and Children's Hospital, and Dr. Charles Macias from University Hospitals Rainbow Babies and Children's Hospital. They'll be sharing their learnings and strategies from this program, and hopefully you will see how these strategies can be adapted and implemented by your hospital. Before I turn it over to our speakers, please note that after the presentation, we'll have a short moderated discussion, and then there will be time for your questions for our speakers. So at any point in time when questions arise, please type in your questions to the Q&A pod. You'll see the little Q&A symbol at the top of your screen, and we will address those questions to our speakers. With that, I will turn it over to Dr. Macias.
Thank you. Welcome to all our audience members. Thank you so much for joining us today. It's really quite a pleasure to be able to share some of this work and, more importantly, some of the opportunities that you have in being able to partner or access our resources. So in this next slide, what you see here, please advance the slide, is the continuum of care within emergency services. Emergency services in pediatrics as an adult care spans a continuum. It's critically important that if we're going to ensure the outcomes of children and optimize all the opportunities for the interventions and the touch points that we have in their lives, in their health care, and in their acute care, that each of these components within the continuum requires optimization as well. So each of these domains of activity across the continuum represents not only an area of need, but as well an area of opportunity to improve those outcomes. From training on bystander interventions to pre-hospital pediatric preparedness, to ED readiness, to injury prevention, each represents a place where we can truly make a difference. So what does that look like? We turn to the next slide for some of that data.
So greetings, everybody. My name is Deanna Dahlgrove. I'm one of the co-PIs for ASPR supported Region 5 for Kids. And I wanted to sort of set the stage for everybody. You can see by these multitude of numbers up here that children make up about 25% of the population in the United States. And they do have unique healthcare needs, which I think does not go unrecognized among people when they start to take care of kids. And you notice that about 30 million of those kids are actually seen in emergency departments or have some kind of influence in the emergency care system throughout an entire year. So it's really important to understand how ready our hospitals are across the nation to take care of kids in emergency departments. So we're going to get into more details about this 69.5 over 100, a median score for emergency department readiness in the United States a little bit later in this presentation. But that's an important number to kind of remember, is that it represents that, that leaves only about 70% of our hospitals are really able to take care of kids in the United States. And when we look more specifically into those details of that readiness score, we also notice that when it comes to disaster planning, only less than 50% of our hospitals have pediatric specific disaster plans. So once again, it's important to sort of look at the continuum that about 25% of our population are children, and there seem to be deficits in the ability for our hospital systems across the US to be able to take care of them. Next slide. So this is the why. Years ago, there was a study done on by the Institute of Medicine that looked at emergency care for kids, and it looked at what is going on in our emergency care system. It identified many issues that exist for care for children, both on the EMS side as well as in our care and emergency departments, and found that we really need to approach how we take care of kids and why we need to do this. Next slide. So I think that these were sensational articles that were posted within the past year on stories about children in emergency departments and what happens across our nation. The first one is from the Wall Street Journal. It talked about a child's story and how ERs are taking care of kids across the nation. And I think that it just highlighted some of the deficits that actually exist out there. The Washington Post just recently posted one that most ERs are just not really fully prepared to handle children in emergencies. And so not only are we are looking at trying to fill those gaps and help hospitals understand where and how they can fill those gaps, because we have resources and we want to be in the space to actually connect to and actually fill those gaps, as opposed to having these kinds of articles highlighted in our national news network. We'd rather have that ERs are really prepared to take care of emergencies and that they've accessed resources. So we'd like to turn the story around. Next slide. So when we talk about measuring emergency department readiness, this is based on the national NPRP study, which was conducted back in 2021. So it was actually a survey of over 4,000 hospital emergency departments. And they looked at 7 domains of quality, from leadership to quality improvement improvement projects, as well as looking at things like disaster preparedness. So what they did find, though, is that when you actually look at these, that as hospitals actually improve their readiness scores in these 7 domains, you actually lower the mortality for children, especially for critically ill kids, and you actually lower the mortality for injured children also. So there are means of actually improving your readiness scores on everyday readiness, but we also look at readiness as a baseline for, if you can take care of one child on one day, you can actually be ready to take care of children in disasters. So we actually use it as a context for thinking about disaster preparedness also, noting that in hospitals, we only had less than 50% did not actually have disaster plans for children. So next slide.
So Deanna spoke about the 7 competencies or 7 domains of quality improvement within the National Pediatric Readiness Project, and those are illustrated here. What's important to really think about is that a hospital may have many of these functions already built within their processes, within their structures, and are tracking outcomes related to it. But it's not the same to have them existing if they aren't able to break down and be specific to children. Provider competencies that can deal with the neonate as well as with the child. Quality improvement interventions or strategies that are targeting pediatric improvement models. Policies, procedures, and protocols specific to the diseases and the ages that we are concerned about within the pediatric population. Patient and medication safety, recognizing that weight-based dosing is a critical area of risk for pediatrics specifically. Support services, the consideration of the needs of children, such as with social work or with community health workers or with child life. Equipment, supplies, and medications that are also specific to children. Smaller ET tubes, for example, example. And then finally, core to all of that, the administration and coordination of these pediatric services, such as that which we see with pediatric emergency care coordinators, people that are specifically designated to look for the needs of children within a hospital structure, its processes, and its tracking of outcomes. All of this has been most recently codified by the American College of Surgeons in the Committee on Trauma, as it has mandated the integration of pediatric readiness assessments and the description of plans for gap closures in hospitals of any type that are undergoing trauma verification. So many of you are already seeing these regulations. So when did many of these support services start? When did these structures begin to exist within the federal government? That's illustrated in the next slide within this timeline. So as early as 1984, the Emergency Medical Services for Children program was authorized. A very small program, really intended or charged with tasks related to the integration of attention to emergency care improvement for children embedded within the adult emergency care system. So we were seeing improvements on the adult side in relation to trauma and cardiac disease management of strokes, for example, as the healthcare system was investing heavily in 911 systems and emergency systems, including pre-hospital systems. But it would be another 2 decades before we were giving that attention to both the processes and the outcomes for children. So fast forward to 1991, where the Emergency Medical Services for Children began targeted initiatives grants to focus on specific areas for growing innovation. And that was partnered in 1997 with the emergence and expansion of emergency medical services for children state partnerships. 57 states and jurisdictions that would create the foundation for EMS for Children's framework by which we could launch many of these improvement strategies. In order to add to the armamentarium for much of this work, we really needed to grow the science. And so in 2002, the Pediatric Emergency Care Applied Research Network was started, now with over $100 million in federal and private funding. That research is really growing our knowledge for things like traumatic brain injury rules to identify patients at low risk, therefore being able to avoid CTs or other imaging. Lots of great science has come out of this. That began to move forward into a number of national pediatric readiness project initiatives that then moved us away from just the emergency department, but the emergency department and its partner in pre-hospital pediatric readiness when that launched in 2019. That brought us to 2019 initiatives across the ASPR, the Administration for Strategic Preparedness and Response, as they launched 2 pediatric disaster centers of excellence that you'll hear more about, that then grew to 3 in 2022. Fast forward to 2021, we're now in the midst of the pandemic. We're recognizing the unique needs of children. In 2022, we're seeing the surge in the triple-demic. Then with the recognition that we were seeing capacity and capability challenges for children with an exacerbation of disparities, a mental health crisis, a respiratory surge, COVID-19 beginning to define new diseases and new manifestations in children, there was a real need to create the Pediatric Pandemic Network. All of these assets working together to create a new framework. So we'll start with the first of these to do a little bit more of a deep dive, illustrated in the next slide.
So when we talk about the ASPR-supported pediatric disaster care centers of excellence, who were funded back in both 2019 with 2 centers, the Western Regional Alliance for Pediatric Emergency Management and then Region 5 for Kids. and then a third being added in the Gulf 7 in 2022. These have really been important initiatives supported by the federal government to really look at regional disaster planning for pediatrics in these areas. And you can see listed under the bullets which states are actually covered. But we like to think that we're not just confined to the states. We often are asked by other states that know about us to reach out to us, and we want to be an asset to everybody in the United States across the board. And we like to work together to disseminate our best practices for pediatric disaster preparedness and demonstrate how it looks. We have a combined website, which is actually linked on this slide also. We encourage you to visit it to be able to get to our individual websites in addition. Next slide. So these are the pillars upon which the Pediatric Disaster Centers of Excellence are built. We really are seeking to coordinate pediatric disaster care capability across regions, not being confined to state lines, really strengthening our disaster preparedness plans and coordination with all of our partners that exist at both the local, regional, and state level, and working across those state lines to really increase capacity among state assets that may exist. Looking at how we enhance that medical surge capacity through our educational competencies and initiatives across the board. And we also work hard to create a situational awareness of what pediatric disaster care is across the spectrum. What are the assets that exist, and how can we actually coordinate those? We seek to really not stay within our academic medical centers. We really seek to have real world people contact us with their problems and understand how we can actually help them close the gap. And we're really focused on the operations of the day-to-day as well as those disaster situations. Next slide. I'm going to turn this over to Dr. Dennenberg.
Sorry, I had to get my volume on. So, we're talking about the networks and how we're collaborating for pediatric readiness. And one of the ways that we really want to make sure we're contributing to pediatric preparedness and readiness capabilities is we really want to use these networks to approach experts in the field to help drive the change across the country, quite frankly. If you look at where these hospitals are that are participating, we have subject medic experts everywhere. We have trusted coalitions. The preparedness and response efforts have been robust. Real-time situational awareness within regions is really important. And I'm going to share in just a little bit some work that we've been doing for situational awareness that we started in one region and is ready to spread across the country to every hospital in the country so we can be more ready for pediatrics. Of course, there are gaps in pediatrics specific preparedness and pediatric specific care in our hospitals across the country. We only have about 120 or 140 pediatric hospitals or children's hospitals in the country. We take care of a lot of kids outside of those hospitals. And so the opportunity to address those gaps is important within this work. Creating resources to educate pediatricians, educate emergency physicians, educate hospitals, educate administrators and operators. And of course, the discussions are inclusive of disparity and inclusion. We know that there are disparities across the country in how kids receive and are prepared for care. And so that's an important part and one of the important pillars of the work that we're doing. Next slide. So when you look at the partners, this is really a busy slide, and I'm not going to read through all of these, but if you really look at how we're surrounding children and families and how we're surrounding preparedness for pediatrics and for kids across the country, again, referring back to some of those articles that Deanna mentioned, we're working with Hospital Association, we're working with federal partners, actually CDC's reached out to us, we're working with pre-hospital agencies, we're working with public health agencies. All of these listed here are all part of the work that we've brought into these coalitions and into these collaboratives so that we can continue to bring not only the knowledge and readiness for preparedness, but again, isolate, find those gaps, and be better prepared to take care of children. And again, as Deanna mentioned, we take care of a lot of children in the United States in hospitals outside of children's hospitals. And so this work with all of these partners is essential. And again, one of the reasons why we're talking to you today at the American Hospital Association. Next slide.
So the emergency medical,
Charles.
One of the Emergency Medical Services for Children Innovation and Improvement Center is one of those
You're
networks.
muted, Charles.
Apologies. Can you hear me now? I'm showing as unmuted. Yes, wonderful. The Emergency Medical Services for Children Improvement and Innovation and Improvement Center has two coordinating centers, both in Dell Children's in Austin and UH Rainbow in Cleveland. That operates out of four critical vertical domains: pre-hospital care, trauma care, and disaster preparedness. I mentioned these areas of focus because the interaction of these all represent opportunities where, as hospitals, we can really engage in opportunities for improvement. All of these sit on a foundation of the 57 state partnerships that I described earlier, with the cross-cutting domains of quality improvement strategies such as advocacy, research, clinical practice guidelines, analytics, and alignment with value-based care initiatives. What does that look like nationally? You'll see that in the map on the next slide, where you see the hub sites of the Pediatric Pandemic Network called out by name. You'll see the circles being the key centers of the Emergency Medical Services for Children Innovation and Improvement Center. The ASPR Disaster Centers of Excellence specific to pediatrics are represented by the squares, while the diamonds represent the RDHRSs, which are the Regional Disaster Health Response Systems of the ASPR, which have pediatric partnerships aligned with them. Today, as a network of networks, there are potential partners for any hospital that is seeking to improve everyday and pediatric readiness. All 57 states and jurisdictions. This map looked nothing like it looks today 10 years ago. So we're delighted to have partners that can collaborate with you in every facet of care. And what does that look like when we talk about these facets of care in disaster medicine? If you look at the next slide, you'll see the structure within the Pediatric Pandemic Network spanning 23 domains of work as national task force groups. Each of those groups comprised of the nation's subject matter experts that are seated within that space. That is these domains such as capacity and capability. So how do we manage surges? How do we address pediatric issues with chemical, biological, radiologic, and nuclear threats? How do we think about deployable assets, DMAT teams? How do we conduct drills and exercises? How is health information portability across the states pertinent to all of this work? How do we think about reunification of children when there's separation during disasters? And probably one of the most near and dear to us in the current supply chain shortages with IV fluids, how do we address these critical threats during disasters, pandemics, epidemics, or as a result of any of those? So the intent of the PPN is really to grow the number of children's hospitals hub sites with affiliate sites to serve as champions as well as implementers within and in partnerships of their community stakeholders. That's inclusive of schools, community hospitals, etc. Lots of opportunities to engage with experts in all of these areas. Next slide. So does pediatric and disaster readiness really significantly impact hospitals? I think the answer to that really lies within three buckets. And those of you that are familiar with the Donabedian framework really have this opportunity to think of the framework as giving us a way to think of the challenges to readiness for children. That improving structures is important in order to improve and monitor processes specific to children in order to get to better outcomes in children. So let's get more specific through some of the examples that Dr. Dalgrove will walk us through in the next slide.
So I think that some of these are just really specific examples about what has happened, I think, over the United States over the past 15 to 20 years. There was a study done that looked at inpatient beds, and there may be some of you on this call that have, real world experience with this, but pediatric inpatient beds have decreased over the past 20 years or so. And I think what we've noticed then is that when children need care on an inpatient unit, they have to go further to get their care. They can't stay in the rural areas. And the other thing that's happened too is that critical care beds are only now in children's centers. They're not even in the more robust hospitals that might have some inpatient services, that might have had a small critical care unit at one point. So they're now really concentrated in our academic medical centers, which really makes it a challenge for families that have to travel really far for inpatient care. And so we're going to go to the next slide. This is just one example. So I think another example in our most recent past is probably the respiratory surge of 2022-23. Infants and children were really affected at a much higher rate than usual. And there were a lot more critical care patients at that time. And you can see this is just an example of the RespiNet from the CDC's actual viral load that was actually happening in that time frame. So it just gives you a really good idea of how we were impacted during that time. And there's a lot of theories as to why this happened, but I think the thing that's most important is what happened to pediatric hospitals and in combination with their usual referral patterns. So next slide. So the landscape is that pediatric ICU beds were really strained at that point. As we know that we do have pediatric ICU beds, but they're primarily concentrated in the pediatric hospitals. So anytime a child needed a critical care bed, community hospitals were looking for those critical care beds, but oftentimes they were full. So this meant that community hospitals were having to make multiple calls to be able to find that critical care bed. In addition, those hospitals were relying on their usual pre-hospital transport services to take care of these kids. And so what ended up happening is you had pre-hospital services that were transporting more critical kids than they were usually able to do. And a lot of times they would actually refuse to transport those kids because they didn't have the training to actually transport these sicker children. So there was even a longer wait then for the pre-hospital services to be able to transfer these children to more to their appropriate care at children's hospitals. And there was also a need for pediatric hospitals to really share a lot of information about what their bed availability was and things like that, both with state partners and across state lines, because as we know, children and families are not going to they're going to go to the closest hospital that they can, and that might be across a state line. And so that's an important caveat to remember. Next slide. So pediatric hospitals did adapt during this respiratory surge. We expanded our ICU and we would take lower acuity patients and we would put those onto other floors. And so we actually would manage some of our ICU patients on some of our lower acuity patient floors. We had just-in-time rapid credentialing for staffing, so we could increase staffing. We might add ED physicians into an emergency department to help manage some of the pediatric patients. We would have just-in-time training with adult respiratory therapists or adult nursing staff so that they could come over and help with our staffing, as well as looking at relaxing staffing ratios during those opportunities. We also had medication substitutions during this time. We were running out of albuterol nebulizer solution, so we actually had to turn to MDIs during this time frame. And this was also the chance for when we talked about creating situational awareness for pediatric hospitals, but actually just for the community hospitals, we had the concepts developed in several locations across the country where they developed pediatric medical operations coordinating centers so that you could understand where the critical care beds, you could understand how to be able to do your transport assets. So next slide. And I think that during this respiratory surge, the ASPO was very intentional in creating 10 town halls that we actually were able to have the Pediatric Centers of Disaster Excellence participate in. We are actually able to listen to hospital administrators and emergency managers and coordinators, and we are actually able to understand what was happening across the country through these town halls. In addition, our partners in RAPN created a pediatric surge playbook that is based on a community level surge. So these are all important contributions that I think existed as a result of this respiratory surge. Next slide.
All right. So, one of the things about the surge report, the things that we learned from the surge is obviously with the respiratory surge, we learned firsthand what Deanna was talking about. We don't have enough pediatric ICU beds. We know that they're concentrated in academic centers, which happen to be particularly in urban centers. we knew that we needed some sort, and we learned from this, some sort of situational awareness. What's going on in our children's centers across our states and across the country, so that we could be ready to have kids get care where they need it. We could be ready for disaster, surge, or quite frankly, a normal respiratory season at times. So we disseminated tools for just in time. We did some work around the pediatric surge report, participated in 10 ASPR-hosted region webinars. So the work that's coming out of these groups that Charles and Deanna have already presented is already giving us playbooks for the future. And so that's the strength of this work. Next slide, please. One of the things that we learned in 2014, before we'd ever heard of respiratory surge or before we'd ever heard of COVID, was in Michigan, we knew we had about 12 centers that provided 90% of the pediatric care, or at least higher level pediatric care. So we had been getting together for a couple of years, meeting weekly during heavy season, and we knew we needed some sort of tracking mechanism to know what our children's hospitals were capable of. With our partnership with the Michigan Hospital Association and Michigan Department of Health and Human Services, we actually developed a dashboard with our state, with one of the vendors that leads our data mining or data dashboards for the state. And we created a dashboard that we can use in real time. Really simple fields, was in every single hospital in the state, gave us pediatric ER physicians an opportunity to look in any moment where there's an asset that we can move a child to, or where we know there's assets in the state for sick kids. When we learned about ASPR and PPN and the COE work, and we joined the network, we recognized that this dashboard actually was available in 30 states across 60% of the hospitals in the United States. And so where I'm going with this is there's an opportunity for a simple fielded real-time dashboard for pediatric assets across the country. Last week, we're partnering with Mercy Children's. They're doing some work with another vendor, and we're going to work simultaneously and hopefully develop a dashboard that can serve all 50 states, Puerto Rico, and all areas especially during a disaster, but actually any time. So don't worry about this dashboard itself. This is just to show you that we do have a dashboard. Next slide, please. We talk about the impact of being PEDS ready, and we talk about, our children's hospitals are ready. Our dedicated children's hospitals are ready. But really, we know that if we can increase pediatric readiness across all of our hospitals, 76% lower mortality rate. Think about that, 76% lower mortality rate, 60% lower mortality rate in injured children. That's our trauma patients, and at least 1,400 children lives saved each year. This work is really, really important in recognizing the need to be able to take care of children in any of our emergency departments across the country, and then using tools like the dashboard and the other tools we're creating to be able to get those kids where they need to go when the resources are not available in a ready ER. Next slide. We always talk about the cost, right? There's always the cost. How can we be ready for children, especially in a smaller, more rural hospital that predominantly takes care of mostly adults, except for in the emergency department? And research really shows becoming pediatric ready is not that costly. $4 to $48 per patient served. That's less than a vaccination. The cost effectiveness and health impact of increasing emergency department pediatric readiness, there's articles, there's research that shows that it pays for itself, not only in cost savings, but it pays for itself in care for the kids in our community. So we really have to get to a point where everybody is PEDS ready across all of our hospitals. I'll pass it back, I think, to Charles to bring us to the close.
Next slide. So Deanna led this discussion on the public view of where we as hospitals sit with pediatric readiness. But it is important for us to really recognize the successes and the best practices by hospitals within the pediatric readiness space as much as we recognize the gaps. So while the Wall Street Journal article focused on those gaps, they did subsequently offer examples of best practices, and that's illustrated in the next slide. To tie in all these descriptions that Dr. Denenberg described earlier with the cost effectiveness of doing the pediatric readiness work, this particular story focused on Grand River Health Hospital that improved readiness through a number of initiatives, appointing child emergency coordinators. These are the PECs, pediatric emergency care coordinators, color coding medication equipment that's stored in the ED based on child size, training ED physicians to perform procedures on children, such as how to create emergency airways, and educating physicians on CT scan guidelines and revising computerized protocols to better inform treatment decisions, clinical practice guidelines. So all of this was done relatively inexpensively, as you see in that last paragraph within the inset there. Nominal cost, minimal. It's that institution is now sitting at a pediatric readiness score of 97. A community hospital that is not a children's hospital. A wonderful success story. We can, in fact, turn the narrative by really investing in pediatric readiness. What is the next slide? So what can we do to get pediatric readiness to a disaster readiness state? What can we do for everyday and disaster readiness as hospitals? We can support facility recognition programs. These are programs that are being established across the U.S. That empower pediatric emergency care coordinator training. So create within a state an opportunity to enhance the number of pediatric care coordinators. Emergency medical services for children through their state partnership programs, 57 of them across the states and jurisdictions, have the capability and already have structures within every state. So if you're a hospital that has never partnered with your EMSC program, a great opportunity to access any of these PEC guidances. Creating state standards and data sharing, opportunities that Dr. Denenberg talked about, but also understanding where there are opportunities to build transfer agreements and other preparedness-related activities. Providing transparency on pediatric outcomes that really carve out not just an aggregate of how are we doing with trauma, but how are we doing with trauma in adults versus children. Really thinking about the way that we as individual hospitals look at our own data. And then hospital level engagement in pediatric readiness surveys and the ongoing QI efforts within the Pediatric Readiness Survey website, and that is provided to you as well. There is an opportunity to engage with the QI toolkits that offer a number of guidelines, a number of transfer agreements, a number of activities, forms, documents that all have the perspective and the lens of improving pediatric readiness. Other things you can do, support pediatric readiness scoring and gap closures in states that have hospital licensures or credentialing processes, very similar to ACS standards. What does that mean? Really codifying and supporting the codification of that so that there is commonality and understanding of what those scores look like and the visibility to the scores. Why does that matter? Because if I see a gap in a certain area and I want to know who's doing this well, it's a great opportunity to reach out to another hospital that's similar in structure or similar in geography, or maybe a critical access hospital where we can see your scores are great in this area. What are you doing that we can partner with, or what are you doing that we can borrow from? And then finally, supporting the creation of a pediatric medical coordination cell or center, these PMOCs that Dr. Denenberg and Dr. Dalgrove talked about earlier. They will provide the capacity and capability of data in near time or real time for everyday information and for disasters. And then finally, providing the pediatric readiness support for community hospitals. How could we work together within a region, partnering with any one of our networks, any one of our task force groups? These are the things that each of you as hospitals, as stakeholders in this work can do to improve pediatric readiness. So with that, I thank you for your time and I turn this over to our moderators.
Thank you all. That was a really fantastic and informative presentation. I get moderator's prerogative to ask you questions first, but I am also sure that our attendees have questions for our speakers. So while we're having this conversation, if you all can put your questions in the chat box or the Q&A box, we'll keep tabs on them and share them with our presenters in just a few minutes. But I want to get started. I remember when we first started talking about this webinar that you all were emphasizing how important it was that this wasn't just for pediatric hospitals, but this is for adult hospitals being ready to serve kids in disaster situations. So I know you touched on this a little, but like what specifically do those hospitals need to start doing to be prepared to be pediatric ready?
Charles, I'm going to jump in here just for 10 seconds, just because I'm an ER physician that's trained in both pediatrics and adult. And the one thing I'd say that before Charles and Deanna answer this is that we don't have adult hospitals. We have pediatric hospitals. We have hospitals that take 30% of our ER visits in our hospitals across the country are pediatrics. 60% of our kids that get care in the United States are in an emergency department. And so and I'm not correcting anybody, I'm just saying that our hospitals are general hospitals. We take care of a ton of kids in general emergency departments across the country. So when Deanna and Charles answer that question for you, just realize our adult hospitals need to be ready for kids because they're general hospitals.
Mhm.
I think that serves as the foundation for the why. So thank you for that comment, Dr. Denberg. And that has been the focus really for any of the charges across the networks, recognizing that in many cases, we are limited to 200 plus children's hospitals, and they should not and cannot serve as the only venues of care for the pediatric population. In fact, the reality is that the real opportunities come in the acute emergencies that occur in the community-based hospitals, which is why pediatric readiness scores and the National Pediatric Readiness Project was really designed for community hospitals, not for children's hospitals. And much of the effort that's surrounding the pediatric pandemic network in the congressional language that that created, and the appropriations dollars that followed that were really done to use the children's hospitals as the platforms, as the vehicles, as the conduits to the knowledge translation, to the opportunities for engagement that would occur within the communities. So the thought that children's hospitals could serve as the partners to the community hospitals means that we can build those relationships. And it's not just limited to the hub sites that you see. The networks are certainly poised to do that, whether it's the pandemic network, whether it's the EMSC Innovation and Improvement Center, or whether it's the ASPR Pediatric Disaster Centers of Excellence. A lot of this begins with understanding the environmental scan. So have you done the pediatric readiness survey? If you're a hospital that has not done that pediatric readiness survey, that's the first step in understanding where are my gaps. Once you've recognized the gaps, the opportunity to begin to bridge those gaps, some of that is provided in the toolkits, but you'll find areas where you may say, this toolkit gets me to X, Y, and Z because it has a group of guidelines that helps me understand and build responses to these diseases that I may not have the subject matter experts or the physicians or the nursing staff trained in this area, but I want more. And that more comes from reaching out to the partners within this network, both children's hospitals and the networks themselves. So I think that there are lots of opportunities from going into those resources, but it all begins in recognizing and doing the assessments to understand where a gap in a non-children's hospital sits. Deanna, any other thoughts?
No, I think you covered that actually very well. I would actually say that, that really the Pediatric Disaster Centers of Excellence, we really work hand in hand with the state supported hospital preparedness programs through healthcare coalitions. And so when you talk about how to improve day-to-day readiness as well as disaster readiness, we really work hard through those healthcare coalitions and the hospital preparedness programs to really look at, how can we increase capacity in especially beyond our urban area hospitals that take care of children, really looking at those rural and critical access hospitals. I think it's really important reaching out to those healthcare coalitions in those areas to really make sure that they understand where we can connect to bring them to the tools that, will help them actually become a little bit better prepared on a day-to-day basis so that if a disaster does happen there, that we can actually assist.
Yeah, and Deanna, it's like you knew what my next question was going to be, and that's really about like the difference between what pediatric preparedness looks like in major urban hospitals versus small rural hospitals, and like what are those key things that rural hospitals need to have set up to be prepared?
Well, we came up through the Emergency Medical Services for Children Innovation Improvement Center. We actually came up with the Pediatric Hospital Disaster Checklist, and it is based on foundational, intermediate, and advanced. There's 11 domains in that, and it just talks about things that they can do, and it has resources that are plugged into it. And I'm really proud to have been a contributing subject matter expert to this, and really promote it, because I think that when we look at hospitals that we consider potentially foundational, that's really hospitals that just have an emergency department where any child can walk in any single day. And what does that look like? So understanding who your community partners are, and when you're in a rural area, you have people that wear multiple hats. They may be the emergency manager, and they may be the pediatric emergency care coordinator in that hospital also. They might also be a paramedic on an ambulance. So we have people that we understand wear multiple hats in these communities, and we want to make sure that they understand that they're really not alone, that we're here to fill that space to help them figure out where the resources are and all those kinds of things. And that's just one example. So when you talk about PEDS readiness and taking the survey, I mean, that's just a really great place to start, because it can help you identify your own gaps, and it can help you start to look at that. And if you identify your everyday gaps, that'll help us when we think about disaster planning also, and really want to think about how that happens on a community-wide level.
I do think that the geography makes it all the more important, because the rarity, especially in critical access hospitals, for example, the rarity of the critical events, the patient who may come in needing resuscitation, or significant trauma to a child, or a disaster that involves children in a hospital that may only see 3 children a day. Systems aren't well oiled to be able to manage that on a daily basis. So having the tools accessible and understanding where you can rapidly find them is really critically important. And it's both structure and process that are going to help our most rural hospitals fine-tune their systems.
Great. Dr. Denenberg, anything you wanted to add before we move on?
Just one word: partnerships. We can have all of the websites and pamphlets and guidebooks and handbooks and webinars that we want, but you got to partner with your local or regional subject matter experts. So your children's hospitals, your state partners. It's all about partnership.
Yeah, let's talk a little bit more about partnership, actually, because we know that response is really a community-wide effort. So can you talk a bit about how you're partnering, both, you're from different health systems that are partnering on this, but who you're partnering with in your community, and who really those key stakeholders are?
Yeah, I'll just say briefly, in Michigan, what we've done since 2014 is every Monday, certainly during high season, we get on the phone with the CMO and the clinical leader from each of the hospitals that serve children in the state. So there's 12 or 14 of us. And we just talk through what we need during RSV season. During COVID, we were meeting twice a week. During the RSV surge, we were meeting twice a week, sometimes 3 times a week. Just that sharing of information. And so what Deanna and Charles are doing with these networks is taking that to the on steroids, right? They're making that every hospital, every region in the country doing this together on a more prescriptive, model. And so you got to be partnering. So locally, regionally, and what they're trying to do is federally.
Yeah, I would say though too that some of the things in that we happen to have our at UH Rainbow, we have our we're in all 3 of these networks, and it's really a great space to be in, because you get to see like through our pediatric pandemic network, we've created youth councils that are really interesting to understand what the youth want to understand about disaster preparedness and things like that. I think we've actually created a mechanism for increasing primary care understanding of how they might be helpful in a disaster, not only how they prepare their offices and how they prepare their families, but how they might actually end up helping health systems which sometimes becomes, our healthcare system has had some interesting changes over the past 20, 30 years. And so I think, having primary care understand that they are really a part of the response to a disaster is super important, whether it be vaccination or medication distribution or just getting information out to families. I think that, it's a really important place to go. And I think that primary care providers are still a very trusted source of information when it comes to disaster preparedness for families. So I think we need to encourage all those kinds of networks. And as I said, in community-wide efforts, we really, we're a partner with our healthcare coalition. You've got to be at the table, and you've got to represent the pediatric interests, so that when we're having conversations with public health and first responders, that they know that pediatrics is there and that we're there representing the interest for children and families.
Julie, I think a lot of the a lot of the success in the work really is in the devil of the detail. It comes down to actually working on the implementation piece. When you begin to recognize, who do my partners need to be? How do I need to understand what those relationships look like and where they become important? I'm going to give the example of inter-facility transfer agreements. If I am working within a community to say, I'm a rural hospital or I'm a smaller community-based hospital, and these are the skills that we have, and these are the types of trauma patients we can manage, or these are the types of medical resuscitation patients in the neonate that we can handle and that we can't, and I want to begin to establish interfacility transfer agreements, I have to have discussions with my community partners, with my children's hospitals, with other facilities to understand when and where, what are the kinds of patients. And even within the process of developing that, I have to be introspective and look at my own successes and failures as a hospital organization to say, I want to be honest about these data, and these are the patients that I'm going to need to transfer under these circumstances within this amount of time. So my point simply being, until you actually implement this work, a lot of what you're learning is really about quality improvement. How do I iteratively change and develop these partners that are going to be critical to the success and the outcomes that I'm trying to achieve with pediatric patients?
Yeah, and I imagine that part of the challenge is that you are planning for implementation and hoping that you never have to implement it.
Exactly.
So
Yeah.
have you had experience bringing your implementation plans to life and had the experience of, having to adjust or pivot based on real world situations?
2022. I mean, the RSV surge, we actually used our dashboard and used our hospital partnerships and used our transport agreements and actually moved kids from Michigan to Ohio, actually, in some instances. I mean, we actually used all of this stuff in a rudimentary fashion because we were just getting started, but we absolutely used it during the RSV surge.
Yeah, and I think one of the things that we have been doing through our 6-state region in Region 5 for Kids is we do a sort of a situational awareness each week of what's happening with volumes and respiratory surges and stuff like that. It's a very rudimentary system, but it's actually really helpful to understand what's happening among our other children's hospitals, and it really helps to understand trends and things like that. So, a national dashboard where you actually have beds available, and now a lot of us, depending on which state you're in, you can actually go in and see what your pediatric bed situation looks like on a day-to-day basis, on a minute-to-minute basis, just depending on how often data is being actually put in there. And we know that that's variable between states, but for the states that are reporting on a daily basis, it's actually really super helpful. You understand where the beds are and you understand what the trends are.
And I think this conversation very much ties into the question in the chat about limited pediatric beds in adult hospitals and how do you assure there's able opportunity for pediatric patients to be cared for in disaster situations. If you know the conditions, if you know the hospitals you're going to transfer to, if you know that you have contingency guidelines that you can share with your local children's hospital that say, in these cases of respiratory concern, here are the guidelines I can use while I have a patient until to stabilize, until I can transfer. This is all the detail that needs to be in there to assure that you have that capability.
Well, and I think one of the great examples came out of actually the state of Michigan, where they actually, during the respiratory surge, they actually did some just-in-time training to some regional EMS so that they could actually transport on high-flow nasal cannula, which was really truly amazing. So that was just one example of how to be able to do something in real time and transfer that knowledge to the emergency services system. And the use of telehealth was super important during that respiratory surge. That was a way for an ICU physician to get on with a ED doc and talk about how are we going to do this. And then you can do just in time training for nursing on how do you set this up in your hospital, what do you do, what do you watch for. And so there are definitely tools out there that we have created and actually have done and used real life during especially the respiratory surge, which we hope doesn't happen this winter.
And Deanna, just because we're on an AHA webinar, I got to do this. During the surge, we used the data in the collaborative to talk to MHA, the Michigan Hospital Association, and MDHHS, and they actually helped lobby for some real-time support. Nurses, respiratory therapists actually sent to our children's hospitals with the help from the state of Michigan. And so MHA was a huge partner in this with us. So that's why hospitals and hospital leadership are so critical in this.
Yeah, and I think that guarantee that when you're developing these plans and understanding all the people that need to be involved in that, all the disciplines, we think about things in a very different way in the pediatric space. And I'm going to refer to the question in the chat about certified child life specialists and where are they involved in the process. They're in the process from not just the inclusion in the event, but in the post-disaster, in the recovery phase, understanding how to deal with PTSD in a child. It's really bringing all the disciplines that are important in pediatrics, codifying them in guidelines, putting that into front and center into training. But we in the pediatric space are often thinking about this on a daily basis and taking these tools where all these disciplines are codified. That's an important value to pediatrics.
That's wonderful. And I want to thank Michelle for dropping some resources into the chat. I assume that she works with one of you. So appreciate her getting those in there. There is a question I want to make sure we have time for about how colleges and universities with clinical healthcare programs can assist in preparing hospitals and practitioners and communities. Have you seen anything in the training space?
Oh my goodness, yes. This is a really exciting question. This is really important that these programs actually are encouraged. I know that during COVID, there was an awfully big surge at both nursing schools as well as medical schools to look at, what do you do with your providers when you can't go to class? And so there was, the chance to actually use them in public health situations and stuff like that for screening, et cetera. But I think the other thing that's really important to understand is that, we're really encouraging disaster education in all levels of training. So, I think it's important, we can have medical school curriculums, we can have nursing curriculums, we can have curriculums in our residency programs. And I know that, we're working in that space because that's how you increase the capacity for healthcare providers at all levels to be able to understand how to do this. And I know that they're working on national curriculums across the board for all levels of healthcare providers. And so I think it's super important that these programs are involved. And I think the other thing that's happened too is that emergency management has started to recognize the nuances that happen to be coming along when you think about the pediatric population. So anybody that's an emergency manager in a community, in a hospital, those are really important people to have educated with regard to the needs of the pediatric population also.
Excellent. Anyone else wanted to chime in? All right. Well, we are nearing the top of the hour, so I have one lightning round final question for the three of you. So as you're thinking about, as the people on this call are thinking about what to take away from this, what are one or two things you want them to do with what they've learned today? And I know that one of them is take the pediatric readiness survey. What else should they take away?
I'm going to launch off that pediatric readiness survey to say Then link, once you identify your gaps, to the toolkits, figure out how to bridge those gaps, because we have a ton of resources from all of the networks that will help you in a very targeted fashion to bridge that. The nice thing about the readiness survey is it allows you to come back and understand at a later date that the changes that I achieve the goal that I was trying to get to. So it's an ongoing opportunity to really understand how process improvement is going in real time.
I'll say one thing. Look at the map that Charles and Deanna put up. Reach out to somebody at one of those centers. We are all engaged in this work across the country, and there is somebody near your hospital that's doing this work, and all of us will answer questions and actually pull you into the work. So be careful. If you ask a question, we're probably going to ask you to help us out too.
Well, yeah, and I was going to say, please reach out to us. I think our contact information is in the slide set. We'd encourage you to visit our website. We actually have stuff for special needs kids and how to, prepare for disasters for them. And we have exercises that we've done, because we know that, drilling for pediatrics can be a little bit challenging, but we encourage people to do exercises, whether it's at your hospital, your healthcare coalition. You can just do a 15-minute exercise and find out what you would do if you had a surge of kids coming in, and you'll probably learn a ton. So, and I would also encourage you to check out the pediatric disaster checklist for hospitals. It's on the Emergency Medical Services for Children Innovation and Improvement website. I think that will be a very useful tool that has a lot of good resources in it also.
I really just want to take a moment to thank Dr. Macias, Dr. Dalgrove, and Dr. Denenberg for all of the work that you do to support children in your communities and get you ready for disasters, and for sharing your expertise with our group. So thank you so much. We appreciate you and look forward to hearing how this work continues to grow. And to our participants, please reach out to them. They're clearly deeply knowledgeable and enthusiastic about this and ready to help.